presentation on ultrasound evaluation of the cervix.
Thank you. This is madam. I'm back again. Thanks for this opportunity. Some wonderful lectures since morning that we had. So, in fetal medicine, when you are spanning across the fetus, I think if I ask you which is the most neglected, or if you don't really concentrate on one organ, it would be placenta. Similarly, in ultrasound imaging, we are more interested in looking at the uterus, especially the corpus part. Cervix is usually neglected or it is ignored most of the times. So again, I am going to stress upon transvaginal sonography only because that is what this imaging is going to give me good optimization of the image. Now you can ask me why I need to image the cervix when I am able to see the cervix in the per speculum examination. Yes, definitely we are able to see the cervix and the cervical lesions on the per speculum. That is which is in the which is going to see in the external, that is the vaginal part. What about the endocervical part? Sometimes a protruding lesion from the cervix, whether it is actually a cervical lesion or whether it is coming from above. So now you would have seen the orientations of the probe. So the same slide I keep telling why, because somebody who is presenting, they should always tell the audience how am I, because unlike fetal medicine, in gynec you have 4 types of imaging. Orientations will be different. Like Mamta madam was showing that you have a reverse kind of imaging. So another one would be using a logo on this side. So I always keep a simple, the technique what I do for the routine. So I'm not going to play this because I've already done it for my endometriosis, this thing. So go slowly, start from the perineum, introduce slowly, ascend into the vagina, then hit the cervix. So here I will go directly to the cervix. Cervix, as we all know, when I start putting my probe and introduce the probe in the anterior fornix, you are able to appreciate this is the cervix, anterior lip of cervix, the posterior lip of cervix. Cervix looks tubular in fashion. Now you have to know how this cervix is getting oriented with the rest of the upper corpus or the uterine counter. So I am able to see that this is an anteverted and anteflexed uterus. I try to keep my focal zone such that the area of interest is at the middle of the image. So what is that you are going to see in cervix? This is how a normal cervix has to be seen. You definitely will neglect, most of us will neglect looking at these areas. Cervix as such being tubular, when you put color, always in gynec I emphasize putting color at low PRF, that is what the settings and the principles goes with, 0.3 to 0.6 as the maximum and the wall motion filters to be low. Here you are able to appreciate it. The stroma is eventually not more vascular. Maybe because of the probe movements I am able to get kind of a little bit of vascularity here, but usually it will not take so much of color. So this is how a normal cervix looks in a routine transvaginal sonography. So this is what we all do. We keep the sector width less. Sometimes we don't look at the cervix, the neglected part. We only look at the corpus, and we definitely lose the information what is there in the cervix. Off late, we are now only when I increase the sector width, or if I bring the cervix itself to the region, or if I bring the cervix to this region of area of interest here, I am able to analyze what is there in the upper lip, the lower lip, and the endocervical canal. So if you have mucin or a plug, or if she is menstruating, any kind of fluid, it definitely tell me more information of the endocervical glands over here. These are appearing normal endocervical glands. Sometimes we have to do, I just come back and show this. Sometimes we have to do dynamic scan where we have to put some probe pressures at the anterior fornix if it is retroverted on the posterior fornix and all, so that if there is any endocervical pathology, if it is going to protrude out to the external os, you will be able to appreciate that. So we'll move to the common and basic pathologies that we see. Benign conditions is a very common, you almost always see in all the uteruses that you try to span across, the Nabothian cysts or the Nabothian glands, which are usually on the either sides of the endocervical part. Sometimes they might be seen in the deeper into the stromal entity also. These are benign lesions, anechoic cystic lesions. Sometimes they might show posterior acoustic enhancement, but they don't have any vascularity, and they are all benign lesions. These are very common, which you all see. What is the mistake I am doing here in the scan again? I am just concentrating only on the uterus here and the upper corpus, maybe in the upper cervix. But if I do as a routine and systemic transvaginal sonography, if I bring back my probe and slowly introduce, you are able to appreciate the bladder, the anterior lip of cervix, the posterior lip of cervix, what is there in between, which is protruding out in between the two cervical lips and into the external os, outside the external os, a tongue-like lesion which is protruding, and it is hyperechoic. So now you got the diagnosis. Yes, because I was trying to do slowly and I'm trying to assess the cervix, I'm able to get this lesion. Somebody will agree, okay, what is there if I do? I always do per speculum examination for every lady. I will definitely not lose this. So why my imaging is going to differ from them? My image, see, in gynec, I always say you don't have any principles like Alara principle and all. If the fetus or embryo is there, you just put color. Always play with color. Color will give you a lot of information. So for example, if I put color at this, you are able to appreciate the stalk-like lesion is having a vascularity like a single pedicle, which is almost coming from the corpus. It's not from the cervix. So here, for example, if somebody, a clinician will say that I am able to see a polyp there at the external os, I'll just avulse it. So do you think she is right in doing it? If you don't know the extent, or if you don't know from where exactly it is beginning, if you avulse it in the OPD procedure, maybe you are doing it incomplete, the stalk may be left behind, she might have bleeding. So in Hindi they say kuch to mitana hai se jad se mitana hai. So you have to go and locate where exactly the stalk is beginning, and then you avulse that, or you remove that stalk from that lesion. The same case when you do hysteroscope, this is what you see. Tongue-like lesion or the polypoidal lesion which is coming out to the external os. You go inside and locate where exactly from it is beginning, and you use your scissors or whatever energy sources or the modality you want to choose to get it bisected or to remove this endometrial polyp. So the importance of doing transvaginal sonography, slowly saying that here again you are able to see a circumscribed lesion here that is standing out. This is soft in its consistency because I am able to slide and put my probe, it is getting compressed, and also I was able to see the planes that are getting differentiated in between the upper lip and the lower lip. So now I did some maneuvers in the same uterus, though the color is different now, the same uterus. I made it anteverted because it was a long cervix. I gave some pressure, so I wanted to know from where exactly it was coming. So again I say, see, if anything black color thing, if you are able to see it is extending towards the cervix, put color, you will definitely come to know that this is actually an endometrial polyp which is protruding out to the cervix. So that is what is going to give a lot of information, though they are cervical lesions. So yet another case to show, always play with color. Now in this case also, if I put color, the color is going to tell me that it is coming from the upper corpus. You can use 3D, not needed actually, 2D is enough. Glass body can tell us that where exactly, to what extent the stalk is having the vascularity from. So you are able to appreciate sometimes, see, if you are not able to see anything on the external cervical canal, but when I am trying to look into the cervix, you are able to appreciate a small echogenic thing which is standing out there in between the two cervical lips, and definitely you will ask me to put color. Yes, the color is taking as a single feeder vessel. Why am I trying to show this? For example, if you had missed this without putting color, and if this lady is for infertility and you have started for ART, like even if it is for your IUI, what will happen? She would have developed good follicles, the endometrium is growing properly, and eventually one fine day, on the day of rupture, you have given the trigger, you will ask her for IUI. The IUI catheter may actually go and block, this will block the IUI catheter, you will not be able to introduce. So these lesions at the cervix, endocervical lesions, sometimes may cause problems, sometimes even with HSG also. So you will not be able to push the dye properly, you will not image the uterus as well. So the importance of doing, there's no other topic for me now, only you will be seeing cervix. So what is this lesion in the cervix? Hypoechoic lesion which is circumscribed in the posterior lip of cervix. This is the anterior lip actually, posterior lip of cervix, as what madam was describing today. It is appearing with classical edge shadows. So yes, it is a cervical fibroid. Yeah, this is a cervical fibroid. Patient may, it depends again on the presentation that patient might present. You are able to appreciate this is the endocervical can. This is the posterior lip of cervix is having the large cervical fibroid. So fibroid, I'll skip the vascularity and all. We have the classical capsular uptake and all. It may have internal vascularity as well, but capsular aspect is more specific. So now when I have mapped this uterus saying that there is a large cervical fibroid, so it will tell the surgeon how should I approach this. When he knows that this cervical fibroid is actually protruding into the vagina, he may not go trans-abdominal or even laparoscopic approach. It is just a vaginal approach where you can give a nick over here and you can reduce this by debulking surgeries. So that is enough. That's some types of mapping. This is what the usually common PG examiner will ask, what is that dome, the lantern on dome of St. Peter's Cathedral, what we call it as. A large cervical fibroid, and this is the upper corpus which is smaller one. This is a large cervical fibroid. It looks like, it is described like that. Yet another case in cervical canal. In the cervical canal, you are able to appreciate a fibroid. But do you think it is actually a cervical fibroid? You are able to appreciate a black color like thing over here. The shadows are black here. That is to tell me likely this fibroid is coming from the corpus. It is not from the cervix. So it is actually a submucous fibroid which has got pedunculated and it has got sitting inside the cervical canal, and the cervical canal is making its way to widen itself to accumulate this. It has not protruded out through the external os. So I have made a mistake. I should have put color here. That would have taken better. So the same case, you are able to appreciate. The surgeon will come to know, okay, now I have a cervical fibroid. Sorry. So now I have a cervical fibroid. We already mapped that saying, I missed it, sorry. So in endoscopy, you are able to appreciate that we are having hindrances to reach in the upper corpus. So we resect this using the resectoscope. Then we later go into the corpus to see from where exactly the stalk is coming from. So this is how because what will happen sometimes as an endoscopic surgeon, if you are given it as only coming from the cervical region, we only scoop it out without looking at the stalk which is there in the upper part. So once bleeding starts, the vision will be hindered. So you will lose that. You will lose that information that actually this is coming from the upper body or the corpus region. So you will go and look for the from where it is actually beginning, and from there you have to resect it. Okay, case of lesion in the posterior cervical lip. It is showing ground glass echogenicities within with hyperechoic flex inside, and you also know in the adnexa and in the POD you are appreciating features of endometriosis that we saw today morning, a small endometriotic cyst and also an endometriotic nodule in the uterosacral. Now I am trying to show a lesion on the posterior lip which is an endometriotic cervical lip lesion. Patient had extreme tenderness while we were doing this, and also she showed features of endometriosis in the pelvis, and there was a very good uterosacral nodule though in the same case. The same case we are able to appreciate when I put my probe in the posterior fornix. You are able to appreciate here a uterosacral nodule in the same aspect. So this is how, whenever you are trying to span across the uterosacral, make sure that you take enough depth. The focal zone should be at this level so that you will be able to locate these lesions better. So this is a case of cervical endometrioma. Now to wake you up from the post-lunch session, what is this abnormality on HSG? How many for unicornate uterus? No, please answer. So rest all believe that it is not unicornate, right? Any differences of opinion anybody wants to say? I have done the HSC for this lady. So this is showing a banana shaped. How many of you want to confirm this as a unicornate uterus on HSG? Okay. Do you think after doing HSG, I will send this patient back with this diagnosis? Definitely no. I will do a 3D, and the same case when I did a 3D, this is what I am getting. What has happened here? Actually, my Leach-Wilkinson cannula has overshooted the septal part, and I was able to image only this part. So, because there was single external loss, if there was a bifid cervix, definitely in my perspiculum examination, I would have got two well-defined bifid cervix. But there was a single external loss. When I introduced the Leach-Wilkinson cannula, it has overshooted this. So, in 3D, cervical 3D also plays a very important role here. For the same case, I was able to assess this, where you are able to see there is a single external os, and this is one canal. Actually, the septa is beginning just as we entered here. This septa is beginning from the cervical canal itself. This is it is leading to one endocervical cavity to the endometrial cavity. This is onto the right side, and here onto the left side. So, sometimes a complete separate or a didelphys or a bicornate uterus, it's not always necessary that you should get the whole coronal plane in one go. You have to take upper corpus separate, because it is for us to diagnose it. So you have to take a cervical 3D also separate. The same case when we did a hysteroscope, there was single external os, and when we directly again entered into the right side of the endocervical cavity. So with some adjustments of the focus, then we have to come back slowly and see from where exactly the septum was beginning. This is, we have entered into the right side. These are the stromal glands that you are able to see. This is actually the septa. This septa is beginning just as we entered the external os. This is leading on to the right side cavity. This is leading on to the left side cavity. So 3D at the lower cervical part will definitely help us to define. For example, in this case, I am able to get two well-defined bifid cervix. It is not a septate cervix. So if I take a vaginal view, you are able to appreciate a thick fibrous band-like structure over here in between. These are two bifid cervix. It's not a septate cervix. Why am I giving this imagings to my surgeon is because I would definitely the management options will differ. Some will never cut this septa, because for us to have a good uterine volume, we need a good corpus for the fetus to grow. Definitely only cutting the upper part is enough till the septa till here. Don't cut this cervical part. They will be more associated with cervical incompetence. So at times I am trying to locate, there is a Mullerian anomaly in this. I was having difficulty whether to say it is a single external os or it is a bifid cervix. So I'm sorry for the poor imaging, but still I am able to see there is one cavity lining here and another cavity lining here, but I was having difficulty to say whether there is single external os or two external os. I might take help of 3D here, where my view line is exactly at the external os, and as I move, this is a corresponding 3D, as I move my probe or ascend ahead, you are able to see single external os. When I go cephalad position, you are able to appreciate the septa is beginning just inside the external os. So this is to say this is a single external os with a septate cervix. It's a case of complete septate cervix. So again, this will help my surgeon whether I should go and cut the, it may not be needed for a good endoscopic surgeon because he can take decisions on the table itself, but this is to show how it is going to help us. This is the same case in 3D. You are able to appreciate you have a single external os. This is the cervical canal. The septa is still here. So yes, that is what I was trying to show you. When you have a septa with a single external os, we need to cut this. When you have two well-defined bifid cervix, many of us don't cut this because if you do that, because you will end up having a lot of cervical incompetence. So what is that warranting? What is that warrants me in whenever I get a case of bifid cervix is, today Mamta madam was telling about all these things. This warrants me, being a clinician, that I need to look for longitudinal vaginal septa if at all this patient is having. So yes, it is difficult to locate sometimes longitudinal vaginal septa in TVS, because if I put my probe in one canal, the other would be collapsed. Provided if you are doing with anticipation a gel sonography or something like that, you will see the longitudinal septa. Otherwise, for me, I will do a per speculum examination and then put the diagnosis incomplete. This patient actually had a longitudinal septa. Yet another cervical lesion is very common, and it's very easy to diagnose this. She is a primee, the corpus is empty, and now you are able to see in the cervical lesion a gestational sac. Luckily, she has come very early, otherwise it should have gone to a higher gestational age, giving a hourglass appearance. So this is cervical pregnancy. So what is that I'm trying to see in the cervix here? This is a retroverted uterus. a retroverted uterus in the posterior lip of cervix, an ill-defined inhomogeneous lesion which is there almost more than 3 centimeters. It is hard in consistency. This may not be actually required in majority when it is so obvious in a clinical examination. I'm trying to show you a case of CA cervix. So when we put color, the color score will be more, and also what is there won't be typical patterned regular uptake of the color. It will be haphazard and more. So it is a evidence to show that it is a case of CA cervix. Sometimes you have a bossulated lesion in the cervical canal, and when you have not done a clinical examination, you have not done, sometimes these might be incidental findings for a radiologist if you have not done a per speculum examination. So when you put color, you will be able to appreciate that this lesion is likely to be a cervical growth lesion, likely to be that is CA cervix. So again, play with the colors. Colors will help define the vascularity, which is irregular uptake and high vascular. You can use the elastography strain here, where I'm very thankful to Dr. Varun Ashok sir. He is my senior from Pune. He has shared this. Here he is able to show in the shear strain that because it is a harder lesion, you are able to appreciate that on elastography, more blue color is there. That is more, it will take in terms of more of being harder, and that is likely to be a CA cervix lesion. So a polyp will not show such blue, more of blue hues here. It will take more of softness. So that is how we need to differentiate. Again, a case of cervical lesions, some lesions may not need, because we depend for CA cervix most often on a clinical examination only. Yes, yet another case to say, this patient presented with pain abdomen, a simple white discharge. I am able to see the cervix looks hypertrophied with few nephrotians, and when we try, I always say that we should put color. She had features of cervicitis on clinical examination. So cervicitis is actually a clinical examination. Sometimes you get a lot of vascularity without losing the pattern architecture of the vasculature. For example, the first slide which I showed, usually the cervix in normal will not take much of vascularity. So yet another case, we had a case of ectropion. Now just to show how an ectropion looks, here hypoechoic lesion in the anterior lip of the cervix, and again rest of the cervix was looking okay. Just to rule out that whether the ectropion is having other inhomogeneous echogenicity within the stroma of the ovary, the stroma of the cervix, just to rule out other pathological lesions in the stroma. So this was a case of ectropion. So that was about cervix that I wanted to share. Thank you so much.